everyone, and thank you very much for joining us for our virtual pituitary conference. This event is part of our We Are Pituitary campaign, celebrating all those involved within the pituitary community. This is one of our pre-recorded sessions, and you can find the full programme and other session information linked in the video description. You can also visit our website, pituitary.org.uk/virtual conference to find out more. We are delighted to be offering this event for free. However, if you would like to make a contribution, you can do so online, by text, or over the phone. Please feel free to chat in the comments or on our social media channels, and any further questions you may have, we will try to answer throughout the week or as soon after the event as we can. I'm glad to introduce Professor Steve Ball this afternoon, who will be discussing Diabetes Insipidus and answering any questions submitted from the pituitary community. Steve is a consultant endocrinologist based in Manchester, and as well as being a member of our medical committee, he has joined us at many of our previous conferences. Thank you very much to Steve for speaking as part of our first online event.
Good evening, ladies and gentlemen. My name is Steve Ball. I'm a consultant endocrinologist in Manchester, and it's my privilege to have been asked to talk to you by the Pituitary Foundation about diabetes insipidus. Over the next 50 minutes or so, we're going to be sharing some background information so we're all on the same page and understand each other's worlds. And then we're going to be moving on to address specific questions sent in by members of the Pituitary Foundation around diabetes insipidus. And I will do my best to try to answer them as clearly as possible. I always start with some rules for how we interact, and they're probably even more important when we're interacting remotely. Rule number one is that endocrinology is really simple. Endocrinologists do two things. We take things away if we're making too much of a hormone, and we give hormones back if people aren't making enough. The problem is that some things are easier to take away and give back than others. And there's no better example of that than when we're looking after people with diabetes insipidus. Because for the hormone vasopressin, which is the problem with diabetes insipidus, we sometimes have issues with the when, where, what, and how to give that hormone back when you're not making it in the right way. Rule number two to remember this afternoon or this evening is that while endocrinology may be simple, some of the people who have endocrinology conditions may not be. We are all the same in some ways, but we're all inherently different too. What that translates to is that the same condition can affect two different people in dissimilar ways, and treatments that work one way in one person may not work the same way in another. And we should remember that diversity this afternoon and be kind to each other, because what might be a simple answer for one person may not be so simple in another. The third and final rule is one I've inherited from my mother, who wasn't the greatest fan of medicine or doctors in the world. She always said the trouble with one doctor is made worse if there are two, because they never say the same thing, and they never mean to, even when they do say the same thing. And if there's anything worse than two doctors, it's three. I'm quite possibly going to be the third doctor in the room for you this afternoon. So if you hear something different from me, different from what you've heard from your endocrinologist in the past, that may be that I'm just using a different word to say the same thing, or it may be I truly mean something different. And when faced with the truly different bit, that might cause a tension for some people. If I do cause a tension and what you hear this afternoon causes a problem, please contact me through the Pituitary Foundation, and I'll try to resolve that tension as best as I can over the coming months. So we're going to be spending a lot of time this evening talking about baths and bathtubs, because that's the best analogy I have for understanding diabetes insipidus, and it's the way I explain it to myself and to our trainees in endocrinology. Humans are hardwired, engineered as a bath to keep the level of water in our bodies the same. There are really only two ways you can influence that level of water. You can turn the taps on and off, or you can take the plug in and out of the plug hole. And the physiology of our bodies works that thirst and drinking are the taps turning on and off, And our kidney is the plug hole, and vasopressin, this little hormone that's made by the posterior pituitary gland, which we don't make enough of when we have diabetes insipidus. Vasopressin is the plug that goes in that plug hole. So we're going to be revisiting that analogy on a number of occasions through the talk. So let's remember taps, plugs, plug holes. It is amazing that our body can maintain the level of water within it and the concentration therefore of salt within that constant over time and over huge variations in our environment, from living in the desert to living in the sunny northwest of England where the sun always beats down and it never rains. Our level of water stays the same within us. It does not do so automatically. We are hardwired to maintain those levels constant through two key processes. One involves the production and action of the hormone vasopressin, AVP in the slide. That's the hormone that we don't make when we have diabetes insipidus, or we don't make it in the right way. And the second important mechanism is thirst. We drink when we're thirsty, we don't drink when we're not thirsty. And the combination of that vasopressin action and thirst is what enables our bodies to keep the level of water in them constant over time. Now that key interacting process of the production of vasopressin and the switching on and off of thirst occurs through the hypothalamus and the posterior pituitary. And that little bright spot there is your posterior pituitary gland, and it's hardwired into your hypothalamus where all the circuitry is that senses dehydration and hydration state. And that hardwiring functionally looks something like this, where your paraventricular nucleus of the hypothalamus, a specific tiny area of your brain, PVN on the slide, and supraoptic nucleus, well, again, another small area of the hypothalamus deep in the brain, the SON on this slide. That's where vasopressin is made. It's processed and packaged as it travels down the nerve cells into the posterior pituitary where it's stored. And it's released at the right time in the right way in response to changes in how the hypothalamus senses our hydration state. And moving to the right-hand side of the slide now, where we have a depiction of the body as a bathtub with an inflow tract and an outflow tract. And water is in blue, and salt or sodium, the major salt of the body, is in gray. We'll see how those two interacting processes, thirst and vasopressin production, work to keep the level of water in the bathtub the same. And it does it because thirst switching on and off and vasopressin switching on and off are inextricably linked. They tend to turn on and off at the same time because they're built to do the same thing. As water is lost through our kidneys, we risk dehydration. That is sensed by the brain and the hypothalamus, and we switch on the production of this hormone vasopressin, AVP. That circulates around the body, gets to the kidney within 30 to 60 seconds, and acts to stop us excreting water. So the rate at which we lose water goes down. At the same time, that same or very similar area in the brain switches on our thirst. So our water intake matches our water loss. Switching on of vasopressin and switching on of thirst and drinking behavior occurs simultaneously. Now, conversely, if we start to drink too much and we're at risk of the bathtub overflowing, the sodium concentration within that bathtub decreasing as we get more waterlogged, then that too is sensed by the hypothalamus, and we make less vasopressin. The plug comes out of that plug hole, and we start to lose more water to our kidney. So the two things, vasopressin production and thirst switching on and off, are the mechanisms by which our body keeps the level of water constant and the concentration of salt within our body the same. So, all on the same page, the themes of the questions that have been sent in are outlined here. And over the next now 30 minutes or so, we will progress through those batches of questions. And in doing so, I hope to address them as best I can. Many of you in the audience may recognize some of the questions as your own. And if so, I hope I can answer them as well as is needed. So the themes that we're going to go through are: what's the cause of diabetes insipidus and how does it change over time? Living with diabetes insipidus day by day. How diabetes insipidus can interact with other medical conditions. Some of the problems about dosing, variation of dose and its effectiveness, and how to manage days off treatment that people experience with diabetes insipidus. And then we're going to end with some key issues that have been raised around diabetes insipidus in pregnancy and reproduction in general. So be patient if you know that your question is buried deep in one of those sections, and I hope we get to it and address it appropriately. So these are the questions that have been sent in around causes of diabetes insipidus and progression over time. Why does DI happen, and how does it affect other hormones? Can you explain a bit about why some patients with pituitary disease get diabetes insipidus swings after surgery and it goes away, whereas for others, they're left with DI permanently? And then finally, is it possible for DI to disappear at some stage after surgery? And the specific person has written in saying their husband has DI, takes it when it takes Ddavp when it's required. It's a small dose, only every 12 hours, perhaps even every 24 hours. That person's husband's been told that their diabetes insipidus could easily stop even after years after surgery. Surgery was in 2017. Things look pretty good at the moment. Has the diabetes insipidus gone? Has it gone into remission? Will it come back? So let's address those themes. And there are more on this topic to follow. So, what's the cause of diabetes insipidus? Well, in your brain, underneath your brain, if you draw a straight line across your two temples and a straight line through your bridge of your nose, about 1.5 inches in there is your pituitary gland. There's a bit at the front called the anterior pituitary gland, and there's a little bit at the back called the posterior pituitary gland, and that's the main focus of attention for us this evening. The pituitary itself sits in a little bony cup about the size of the end of my thumb, and it dangles from the brain by a stalk. That stalk's important because it's through that stalk that some of the hormones that are made within the hypothalamus reach the posterior pituitary gland and the anterior pituitary gland. And specifically for people with DI, diabetes insipidus, the hormone vasopressin is made in the hypothalamic area of the brain. It travels down that stalk and is stored in the posterior pituitary gland before it's released. So let's unpack that, and this is a bit of a gross picture of having had your brain sliced open. This is your pituitary gland. Now that pituitary gland makes a range of hormones from the front, the anterior, growth hormone, all the reproductive hormones that stimulate the testes and the ovary, thyroid stimulating hormone to make your thyroid gland work, ACTH to make your adrenal gland work. But at the back, that's where the business is for diabetes insipidus, because that's where this hormone vasopressin is stored after it's made in the hypothalamic area of the brain. It's stored there and it's released in response to specific things. So damage to that gland, to all of it, to the back of it, to the front of it, can affect the gland's ability to produce hormones, and any inflammation or trauma or radiotherapy or pituitary tumor related disease or treatment can affect the production of hormones from the anterior pituitary gland or the posterior pituitary gland. Today, of course, we're talking about the posterior pituitary gland, that area at the back. So you lose the ability to make vasopressin from the posterior pituitary gland through a variety of ways, one of which is trauma, one of which is surgery, and you develop diabetes insipidus when you've lost 90% or more of the capacity of the posterior pituitary gland to make and release vasopressin at the right time. So you can run on very little background reserve. One can imagine, therefore, that some people who develop diabetes insipidus over time, and we'll come on and talk about the common causes of that in due course, they've progressively lost the ability to make and store the hormone over several years, but they only manifest diabetes insipidus when they've lost that 90% ability. They can run on 15% for a long time, gradually going down 15, 14, 13, 12. When you hit 10%, that's when you develop your problems. So in relation to pituitary surgery, one of the questions that was asked is, why do some people get better from the DI that they get after surgery and some people don't? Well, it's about the degree of damage that's been inflicted on the posterior pituitary gland in that process. And this slide looks at the development of diabetes insipidus after traumatic brain injury. That's a head injury. That's the closest thing we've got to data that might impact or highlight what happens after pituitary surgery. These are data from colleagues in the Beaumont Hospital in Dublin who looked at 126 patients with traumatic brain injury. They lost 24 to follow-up, but they were able to study the outcomes in 102 over some 2 years. Those are the characteristics of the patient: average age about 33, predominantly men. 80% did not get diabetes insipidus, but some 22 out of the 102, that's about 20%, got acute diabetes insipidus after their traumatic brain injury. What happened to those people over time? Did they stay with DI? Did it get better? Well, they were reviewed at a median time of 17 months, a year and a half after their acute event. And 7 people at that time were found to have persisting diabetes insipidus. That's 7% of the original cohort. Of those 7 people with persisting DI, 5 of them came from the group that had it acutely after the head injury. 2 of them came from people who didn't have acute diabetes insipidus after the head injury. Take-home message from this: diabetes insipidus after traumatic brain injury occurs. It's not uncommon. In the majority of people, it recovers. In a smaller number of people, it does not. And indeed, in a smaller group of people still who did not have it at the acute time of the head injury, at the acute moment immediately afterwards, a small number of them develop diabetes insipidus as the years go by. And we can relate that pretty much to what happens after pituitary surgery too. Transient diabetes insipidus is relatively common after pituitary surgery. In by far the majority of people, it resolves quite quickly. In some, it resolves over some 2 years. In a very small number of people who do not experience diabetes insipidus after pituitary surgery, they develop it in the 2 years that follow. As you get further out and the time away from your surgery gets longer, the chances of your diabetes insipidus recovering reduces. So my rule of thumb is one can never say never, but at 2 years, the majority of people who are going to get resolution of the symptoms have resolution of the symptoms. At 5 years, it's increasingly unlikely that your DI is going to resolve, and it's probably going to be permanent. Is there any prediction that we can put in as to whether your DI is likely to be permanent or likely to resolve? Well, again, looking at this data from road traffic accidents largely, it's the commonest cause of traumatic brain injury. The majority of people who had permanent diabetes insipidus were the ones who had the most severe head injury. And again, we can extrapolate from those data to what might happen, for instance, after pituitary surgery. The bigger your tumor, the more damage has been done in removing it, the more likely you are to get diabetes insipidus immediately after surgery, and the more likely you are that it's going to persist over time. Do I ever say it's never going to get better? I use the phrase increasingly unlikely to get better, and then I often reach a point of saying it's not realistic to expect that it will. And that point of it's not realistic to expect that it will get better is around 4 to 5 years in my experience. What are the other causes of diabetes insipidus though? Well, probably the commonest cause of diabetes insipidus, isolated diabetes insipidus without any other hormone problems, is caused by your immune system turning against your posterior pituitary gland and making an antibody against it rather than making an antibody against a virus or a bacteria. It's an autoimmune inflammatory process that gradually destroys your posterior pituitary over time. That's probably the commonest cause of isolated diabetes insipidus. And then there are rarer familial causes where it's inherited. And that's almost inevitably due to a mutation in your vasopressin gene. That means that you don't make vasopressin in a normal way, and what vasopressin that you do make is toxic to the cells that make it, so they gradually decline in number over time. So that familial cranial diabetes insipidus would be the least common cause after autoimmune, isolated DI, and then trauma and surgery and pituitary tumor. So moving on to some of the other questions around causes and progress of DI over time. Someone asked, I seem to be needing less Ddavp. Is that possible? And the answer is yes. That could be that your DI is resolving a little bit and that you're needing less Ddavp exogenous medical hormone to top you up than you used to. Or it could also be that you're tolerating the drive to drink and the drive to pee better, and so you're getting more used to it. So these would be two common reasons why people feel they need less Ddavp over time. Someone asked if I have idiopathic central DI, no other hormones involved, do diagnoses that initially are labeled as idiopathic ever find a root cause? And if so, what's the most common cause? What's the most common finding? We do still use the term idiopathic cranial diabetes insipidus or idiopathic central diabetes insipidus without affecting any other hormones. The commonest cause for idiopathic central diabetes insipidus is the autoimmune cause that I described, where your immune system makes antibodies against your posterior pituitary gland that gradually destroy it over time. And that would be a similar process that occurs for autoimmune thyroid disease or autoimmune diabetes. Final question in this section, is it possible for dosages to fluctuate and to change suddenly? This is a person who has the hereditary familial form of central DI that we talked about a little bit, been on DI treatment since they were 5. It was upped to 3 doses a day when they were 16. Last year they became unwell. Now the person writing in said they became unwell with hypernatremia, but I do wonder whether that was a typo and they meant hyponatremia, because subsequently their dose has been reduced. Well, it is possible that you need less over time. It's possible that your doses do need to fluctuate over time. Many people with DI notice that there are some days of the month where it just doesn't work anymore and they get all the symptoms back, but actually the next day's the magic's working again and the tablets or the spray works. We don't really have a good explanation why that happens, but it's a very, very common experience. In terms of changing doses, moving around over time and how it interacts with your lifestyle or how your lifestyle may interact with your dose needs, we're going to come to discuss that at a later part of the talk, and maybe that will help show some light on some of the issues that this person's having. So the next series of questions was around living with DI day by day. Someone's written in, is it known or proven that caffeine affects DI or has an impact on Ddavp? Because once they've had a cup of coffee in the morning, they can't stop going to the toilet for the rest of the day. So this is interesting because in some people, caffeine is clearly a diuretic. And so many people without DI would notice that. But with DI, you may be a little bit even more sensitive than other people. So yes, in some people, caffeine can definitely impact on your ability to hold on to retain water. It acts as a diuretic. And there are a number of people who experience this day by day. Someone's written in saying they find their Ddavp is so much more effective when they take it on a completely empty stomach. Why is this the case? Well, that's simply because if it's a tablet form that you're using, which I guess it is from the way that you're asking the question, it's simply absorbed more quickly, and food in the stomach and food in the gut commonly slows down the absorption of some certain drugs. I suspect that's what is happening here. And finally, in this section, someone's asked, why doesn't still water quench my thirst as much as sparkling water when my medication is worn off? So this is an interesting question. And again, we now have to introduce a slight complication to how our body works. Why doesn't still water quench my thirst as much as sparkling water, given the volume of water is the same? Well, for that, we need to go back to the physiology again. Because while at the beginning of the talk, I said thirst and vasopressin turning on and off, it's all about your hypothalamus in the brain sensing your state of hydration. There's a little bit more of a complicated story than I alluded to earlier. Because at the back of your throat, and actually in your stomach, are receptors that can sense very quickly that you have drunk something. And that immediate satiety of thirst that occurs after you've drunk something occurs way before the water's gotten into your body and changed your true hydration state. That's a reflection of the act of drinking, putting a liquid in contact with these receptors that sense the fluid at the back of your throat and in your stomach. And those receptors are exquisitely sensitive to water more than any other fluid. And for the person asking the question, their receptors are probably more sensitive to sparkling water than to still water. Many patients with DI say that it's really only water that quenches their thirst, and cold water quenches it more than anything else. But that quenching occurs within seconds of drinking, and that's showing how quickly your body senses that you've drunk water and switches off your thirst. That's mediated by these sensory receptors at the back of your throat and your stomach. After a minute or so, your thirst will probably come back, and that longer term switching on and off of thirst, that's more related to your hypothalamus sensing your hydration state. I hope that helps. More questions around DI, living with it day by day. Can DI be cured? Could it just go back to normal? Well, depends what we mean by cure. DI can resolve, commonly resolved after surgery, as we've alluded to earlier. So that, I guess, would be a cure. And in that case, your body would go back to normal. If you have DI from one of the autoimmune causes or the familial causes, I don't think it's realistic to expect DI to be cured. You can tolerate the symptoms more, you can get used to the drinking and the peeing more, but it's never going to really go away. So I think we need to reframe rather our expectations around that. Someone else has written in saying, what is the most effective and safest way to lose water weight stacked on via intravenous fluids after multiple adrenal crises and having lots of that fluid retained by Ddavp? So this is a difficult one. When you have an adrenal crisis, if you've got multiple pituitary hormone deficiency, for instance, it would be very common for you to be given lots of intravenous fluids when you go into hospital. So that's the equivalent of turning the taps on. If you're still taking your Ddavp, your plug is in. And so we've got that difficult moment where we realize that the plug's in and the taps are on and the level of water in your bath is going up. How do we get rid of it? Well, that can be very difficult without taking the plug out a little bit and certainly turning the taps off. The person who's written in says they've tried furosemide, which is a diuretic, and they've noticed that the hands swell and they're clearly taking on fluid after Ddavp. How do we lose the excess water? Well, going back to our bath analogy, there are only two ways to get the level down. We either turn the taps off, don't give as much fluid, or we take the plug out a little bit, don't take as much Ddavp, or a little bit of both. And my recommendation would be that you do this with the support of your clinical team, that you aim for slow changes over several days, because to do that quickly, to change that volume of water in your bathtub very quickly, that's likely to lead to as much of a problem as the one you're trying to solve. So get some support, get some advice and help, take small steps, look at resolving the position over a number of days. Don't do it on your own. Of course, the best way, what I have to say is the best way is to not get into the position in the first place. And so medics have to be better at judging the amount of fluid that we give people in this situation and making sure we don't overcook people with intravenous fluids when they come into hospital. Avoid getting into the problem. Okay, next section is on how does diabetes insipidus interact with other conditions, or can it interact with other conditions? Someone's written in saying, I get frequent migraines. Could these be caused by a change in sodium levels? My thirst usually drops when I have migraines. That's an interesting question. And then someone else, will there be one day a way to measure sodium levels ourselves, like other people with diabetes do, measuring their glucose, and administer Ddavp at the appropriate level at the right time? This person is very sensitive to the Ddavp. So, could the migraines be caused by the sodium level? Could be. Certainly, variations in sodium levels can change the shape, the volume of your brain. although you've got to have quite significant changes in sodium levels to actually do that. And certainly that could trigger a migraine attack. But it's interesting that you've noted that your thirst usually drops when you have migraines. And that's, of course, because having a migraine is not very nice. and that stimulus, that pain, that what we call nociceptive drive, a noxious stimulus, that's a very good way that you can produce any vasopressin that you still have the ability to make. And it's a very good way to switch off your thirst. It's quite common for people with migraine to notice that they stop drinking. Their thirst perception is switched off, and they probably make a lot of vasopressin, those without diabetes insipidus. I have to say, I have migraines, and one of the things I really notice is that despite my wife always telling me you should drink something, that's the last thing I'm interested in is drinking anything. And I notice that I stop going to the toilet. And that will be because the pain that I'm experiencing is switching off my thirst, and it's switching on my vasopressin, and my plug is very firmly in the plug hole. And then when the migraine passes, my thirst switches back on again. I stop making vasopressin, and I start going to the toilet normally. The issue of will we ever be able to check our sodiums one day and decide to dose ourselves minute by minute, hour by hour with Ddavp? Well, our hypothalamus, sensing our hydration state, is able to switch on and off our vasopressin and thirst within 30 seconds. It's exquisitely sensitive. The desmopressin formulations that we have now, the Ddavp formulations that we have now, are a little bit blunt instruments. They take time to work, they take time to be absorbed, they take time to then wear off. While it's possible in fact we will be able to have finger prick sodium checks, whether that would then effectively mean that I only need to take Ddavp when my body says I'm dehydrated. The problem with that is you'll always be behind what your body is. So by the time your sodium goes up and you've figured that out on a finger prick test, your thirst will have driven you batty, and you will have wished that you'd been drinking, and you will have wished you'd had your Ddavp. So while it's possible technologically now to have finger prick sodium levels, translating that into an effective treatment program that allows you to self-medicate with small doses of Ddavp when and how you need them, I think that is some ways off. And to be honest, I'm not sure that's what we should be aiming for, because we will find that almost certainly that will lead to a reduced overall quality of life. Moving on, does diabetes insipidus have an impact on blood pressure? And if yes, is there any information to explain this? Not directly. Hypertension, high blood pressure is very common. It's likely that if you've got high blood pressure and DI, they are unrelated. Of course, if you've got multiple pituitary hormone problems, you can have low blood pressure if your cortisol levels or your hydrocortisone treatment's not appropriate. But again, independent, I wouldn't worry about that. And does DI have an adverse effect on the kidneys in the long term? Not if we get the dosing right. If you have untreated diabetes insipidus and you are passing over 10 litres of urine a day, that level of urine output can have a long-term adverse impact on kidney function and bladder function. If you have the form of diabetes insipidus that's due to a problem with your kidney rather than a problem with your ability to make vasopressin, we call that nephrogenic diabetes insipidus, then yeah, that comes with kidney problems in the long term. But I suspect the majority of people in the audience this evening don't have nephrogenic diabetes insipidus, they have pituitary diabetes insipidus. I hope that helps. So there were then a lot of questions about dosing with Ddavp, variation, how it works, and what to do with days off. And I've started to list those here. Are certain brands of Ddavp known to work better than others? Or is it a possibility that when the brand has been changed, there may be an interruption with thirst and urine output, etc.? Well, it's funny this, because the pharmaceutical industry and pharmacists will swear to you that there's no difference. And while I don't have DI, I have known a lot of people with DI who will tell you that the reality is that there is a difference in the brands. And that switching from one brand to another, even though the label is the same and the dose is the same, has certainly impacted on how much they've needed to take. I can't explain why. There is something about the different formulations that's clearly different. I'm a physician that listens to their patients, and if someone who's had DI for 12 years or more says it's better on this one than that one, then I get them to get the one that works for them and work with them and the pharmacists involved to make sure they have consistency over time. Not everybody experiences it, but I've heard it so many times, I believe it's the case. Next question. I'm so much better on the spray compared to the tablets, and since I've been on a low-carb diet and lost 11 kilos, I need less Ddavp and I'm feeling wonderful. Why? Well, some people really do prefer the spray. It's got a much quicker on and off effect, and while the off effect can be disturbing, it wears off quite quickly, the on effect, also being quicker, leads some people to prefer it. They have a much more nuanced approach to their control. They recognize their thirst coming on, they recognize it wearing off. They're just much more comfortable on the spray. If it works for you, stick with it. I think I need less Ddavp because I've lost 11 kilos. That's probably because you've lost the 11 kilos. And yet you will need less Ddavp because your bathtub will not be as big, and you'll need less Ddavp to keep the levels of water right. So well done for that. Big impact on your long-term health. Well done. Next question. Why might it be that even though I take the same dose every day, some nights I'm woken frequently, needing to urinate and drink, and other nights not at all? This goes back to something I mentioned earlier, I think. For reasons that we don't understand, it's very common for people to experience the magic of the tablets or the spray wearing off. It occurs a couple of nights a month in some people. I've never had a good explanation for why it occurs, but it certainly does. And it may well be that that's what this person's experiencing. Next question. I seem to be more thirsty throughout the night. I've taken 100 micrograms of Ddavp. Should I monitor my water intake? Well, if you're thirsty overnight and you're drinking the predominant amount of your water overnight, but you're not peeing, then that might be something to do with how you're breathing, with your mouth open, for instance, and you're experiencing thirst because your mouth is dry. So don't immediately assume it's your DI that's the problem. However, if you're thirsty through the night and you're peeing, then it's probably you're undercooked on the dose of your Ddavp overnight. And if you've got a normal thirst, I would trust that, especially if you are noticing that you're peeing a lot during the night as well. The combination of being thirsty overnight and peeing more overnight, to me, means you're probably undercooked with your last dose of Ddavp. And I would speak with your clinical team and ask to see if we can adjust it a little bit. If you're just thirsty overnight but you're not peeing, then I would look for other causes. If your DI is breaking through, it's often we see a combination of drinking and peeing. If it's just drinking, we need to think of other causes, but always bear the DI in mind. The last two questions are about days off. Why do I feel so rubbish on a day off Ddavp to clear the system? And is breakthrough good or bad? So this speaks to the tradition of endocrinologists and clinical teams saying that 1 day a week people should do without their Ddavp to avoid a buildup of excess water. The assumption being that we're probably over-treating some people, and to avoid the buildup of water in their bodies through small level over-treatment over days, we have a day off. So that is the traditional approach. For my clinical practice, I try my best to make sure that the dose is tailored for the person's needs. If I have a busy life and I have a tablet that gives me good quality of life and stops me drinking and peeing, am I going to stop taking it 1 day a week and get all my symptoms back again? Well, I'm probably not, actually. But what I might do is at a weekend choose to have less, so that when I'm around the house and I don't have to do anything, I can offload any water that I've taken on board that's too much, but I have a good balance of my quality of life. So I don't ask people to stop taking it for a day. I ask people to find a period in their week when they're perhaps at home or around the toilet more, and they can have breakthrough symptoms that they tolerate. I ask them to reduce the dose on that day to allow some offloading. Why do I feel rubbish on a day when I'm off Ddavp? I would probably think we can all understand why you feel rubbish if you're drinking and peeing all the time. It's not pleasant. And is breakthrough good or bad? Well, I applaud the aim. I suspect lots of patients don't do it, although they'll tell their doctors that they do. I think it's about coming up with a way forward with your clinical teams to allow what breakthrough is needed, but it's allowed in a controlled manner. It has to be a shared decision how we do that with individuals. It can't be a simple imposition of this is how we do it because this is how we've always done it, and we're going to carry on doing it like that. It has to be through dialogue so that both parties understand what the shared objective is. Then it's a lot easier to come up with a solution. That might be one of the things that other people haven't said before, and I hope that that doesn't cause much tension. But if it does, as I said at the beginning, contact me through the Pituitary Foundation. There's generally a way through. So why is it a problem? Why isn't everybody the same? Why don't we just dose everybody in the same way? Why don't these tablets take it all away? Well, we're going to go through some of the issues that people have on a couple of slides, and I'm going to walk through how I looked after someone who we managed to balance things out to the best effect we could. So clock different preparations of Ddavp, tablet, spray, whatever. The British National Formulary would commonly say that Ddavp treatment, tablets or spray, lasts for 12 hours. And so the commonest thing that endocrinologists in training will do is prescribe Ddavp once or twice a day. If you've got mild DI, you don't mind tolerating the symptoms during the day, but what you want is a good night's sleep. And so some people are underdosed purposefully, and that they take their medication at night. That gives them a good night's sleep. They don't mind the breakthrough symptoms during the day. And so for some people, twice a day is fine. It works. And if it's working for you, let's stick with it. In some people, though, it clearly doesn't last for 12 hours, and it lasts more like 8 hours. If we have overlapping dosing at the right time, then that would seem to be a good idea. But of course, depending on when you start your time clock, that would involve you taking a tablet at, for instance, in this case, 11 o'clock at night. Many people don't want to be taking a tablet at 11 o'clock at night, but 3 times a day works for some people. In the real world, though, it's more likely that people experience this. where the medication works variably between 6 and 8 hours. And there are breakthrough periods during the day when the medication wears off before they take their next tablet or their next spray. And of course, those are problem times for people. You don't want to be suddenly switching on your thirst and peeing when you're going to bed. And while many of us get up at 6 o'clock in the morning, it would be nice not to have to on some occasions. So we have to work with people to tailor a regimen of treatments that works for them around their lifestyle and around their time clock. Some people are shift workers, some people stay in bed late, some people go to bed early. There needs to be an interaction between the clinician and the patient to match the medication and the person's needs. Everybody's a little bit different, and some people are very different. Not only that, some people may change over time as well. And we're going to go through Alexandra's story about what it's like when your lifestyle changes and how you have to adjust your dose or the approach to treatment with your clinical team. So Alexandra was a policewoman, is a policewoman, I should say. Started off with a desk job, had DI in an office, lots of toilets around, happy to take Ddavp tablets twice a day. Small dose in the morning, bigger dose late evening, carried her through the night, 8 till 4 or an 8 till 5 working day. This worked for her, not a problem. These are the plots of her serum sodium levels over time, very stable, no problems at all. Alexandra's diabetes insipidus then doesn't change, but Alexandra's life does. Alexandra goes out on a beat routine. No longer at a desk, no longer having a more static, stable 8 till 4, 8 till 5 day. Suddenly running into problems. Of course, what you don't want to do as a policewoman is having to stop all the time and go to the loo. How do you not do that? Well, Alexandra puts up her dose of Ddavp. She's now taking a total of 600 micrograms a day, having previously been on 300 micrograms a day. She does that because her lifestyle's changed. She's now outdoors more, and she hasn't got access to drinking and toilets. What happens is that the price that Alexandra pays for controlling her trips to the bathroom is told in her serum sodium concentrations, which clearly show that she's over-treating herself. Her serum sodium concentration is going down significantly on a number of occasions, implying that she's holding on to too much water, and that's a direct consequence of her putting the dose of Ddavp up. Completely understandably, because she wants to avoid going to the toilet so much. How do we resolve it? Well, Alexandra wanted to move away from the desk job. She wanted to be an active policewoman. That didn't necessarily mean being on the beat. So we worked with Alexandra and her employer to find an employment opportunity that allowed her to be fulfilled in her career as an outdoor police person, and that was in a car patrol. And then we modified her doses of Ddavp so that she had a smaller dose of oral medication, as laid out here, but she also had a spray that she could rescue herself with when she required it. So the total dose of Ddavp, again, was higher than originally, much lower than when she was on the beat, and she could use it flexibly with support, regular checks in, regular phone appointments, so we could see how things were going and we could adjust as the days went by, and her serum sodium became stable again. So I guess I show that as an example of how clinicians need to work with their patients to adapt around their lifestyle, modify their lifestyle where it can be modified. And it's a little bit of a dance, and it takes some time and it takes some finessing. But if you do that, you can get good outcomes, and people don't have to overly compromise on their quality of life or their career choices. It's the win-win, and that's what we should be aiming for. So the final series of questions were around pregnancy and reproduction. Is DI more common in women than men? Not that we're aware of. Could ADH, antidiuretic hormone, that's another name for vasopressin, could ADH levels secreted, and obviously this person ringing in feels that they have some already, could it be linked to the female hormone cycle? I appreciate this is another part of the pituitary gland, but has there been any connection noted? And a linked question, is it normal to have worsening symptoms on your period? I always need more Ddavp. Well, the great thing about endocrinology is that it's all connected. And while your thirst and production of vasopressin remain remarkably constant over time, there are occasions when it changes. And one of those occasions is in the luteal, or the second part of the menstrual cycle. It's very common for women to feel as though they retain water during the luteal phase of the menstrual cycle, the last 2 weeks of the menstrual cycle. And in fact, you do retain water. You retain water because your body's hardwired to actually do that. And so it's very likely that you experience thirst, and your Ddavp requirement may alter slightly during the second half of a menstrual cycle. So yes, it's real, and yes, it occurs, and yes, it is linked. Again, talk to your clinical team. Some people just notice it, but they don't have to adjust their treatment. Some people notice it and they have to adjust their treatment. Speak to your clinical team. Depends a little bit on how it affects you, but it's real. Can DI cause problems in pregnancy? And is pregnancy advisable for those with DI? And someone else called in, I have idiopathic diabetes insipidus since the age of 3, use Ddavp to control it. I'm now 30 weeks pregnant with my first child and can't find any information about birth necessities or if my little boy will need tests when born. I'm worried about dehydration and sodium levels for both of us. I have an endocrine consultant as well as an obstetrician, but I'm still yet to find out their opinion on the method of birth, as they have not experienced anyone with DI giving birth. So, can DI cause problems in pregnancy? Is pregnancy advisable for those with DI? DI should not be a barrier or an obstacle to pregnancy. Our aim as endocrinologists is to return you to a normal life. If you wish to get pregnant, we should be supporting you to do that, and DI should not be a barrier. Can DI cause problems in pregnancy? It can change, and the obstetricians and clinical teams involved with someone who becomes pregnant with DI need to switch on. It's very common for the requirement of treatment to go up during pregnancy. Why? 2 reasons really. When you're pregnant, you retain more water, so you need more help getting that water on board and keeping it there. And the second is your placenta is very good at breaking down some of the medications that we use to treat diabetes insipidus with. So you need to almost certainly be telling people that you have DI, and don't be surprised if there's a little bit of a dose adjustment that's needed. There is no evidence that women with DI can't have a normal labor and can't breastfeed. That would be important to say. And so for the second question, can there be problems? I'm clearly a little bit worried about the little baby too. My obstetricians and clinical team don't seem to be that confident. If you have familial diabetes insipidus, then there's a risk that the baby will be born and will go on to develop diabetes insipidus if it's the familial form. It's very unusual for that to present in the first few days of life, and you should know by now whether you've got the familial form or not. And if you do, then there'll be other members of the family, and that would be the way to tell, really. You should bring it up with your clinician if they haven't thought of that. It's unlikely to cause a problem with your little baby early after birth, but it's something to be aware of. What we really need to do here is skill up the clinical team, the obstetrician, and the clinical team involved with your endocrinology to be able to support you appropriately. And I'm getting the flavour from this that that's not the case. I can really help with this. If I know where you live, we can speak with the people involved, and the Pituitary Foundation can really help you through this. We should be aiming for a normal pregnancy. We should be aiming for a normal delivery, if you wish one. And both you and the obstetricians and clinicians involved in your care, the only thing they really need to be aware of is they need to be a little bit careful about giving you a lot of fluid during labour. If you're taking your Ddavp, we want to avoid a taps on plug-in moment. So it'd be worthwhile actually talking about that. The other thing to be aware of during pregnancy, of course, is that towards the mid and certainly in the final trimester, it's very common for women to get urinary frequency as their bladder is pressed on by the growing baby. It's very important we don't see that and interpret it as my DI is getting worse and take more Ddavp. So again, conversations with your clinical teams will really help you tease out how much is your bladder being pressed on, the sensation I need to go to the loo all the time versus my DI is out of control. That will regain you the confidence that you need. And we need to skill you up and the clinical teams around you to be able to go through pregnancy normally, and let us know how we can help best, because really this is something that we should be supporting you to do. So, over the last 50 minutes or so, I hope we've shared some common background that enables us to understand a little bit more about diabetes insipidus, how it occurs, how it impacts on people's lives, and what the treatment is. And we've covered a series of questions that have been sent in from members of the Pituitary Foundation, and I hope I've been able to address them appropriately. I'd really like to thank everybody for their time. I'd like to thank the Pituitary Foundation for asking me to talk. I hope it's helped. If there are further tensions that fall from this, let me know and I'll try my best to answer them. But I hope you enjoy the rest of the conference. And I hope this crazy time that we're living in at the moment stops soon. Thank you.